Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Welcome to this issue of Bristol Health Cares. I am Kurt Barwis, your host. We have an exciting guest here today, Sophie Whitlock. Sophie, welcome to the program. Tell us about yourself.
Okay, so my name is Sophie Whitlock. I've been one of the hospice nurses at Bristol Home Care and Hospice for the past 30 years in home care and hospice and additional 5 years at the hospital. So I was actually one of the first nurses to go out and do hospice visits for our Bristol Hospice Agency. It was a pretty cool opportunity.
So I was trying to count the years. So 30 years in hospice
and 5 years on the nursing on level G. I worked.
So you started
years.
Right in kindergarten and just jumped right in.
Yes, I did.
That's
I
great.
started very young.
So what I think is really amazing is I've been at the hospital 17 years, and you're one of the people that I always see you coming in and out of the hospital and say hi to you, and I've been to a lot of the celebrations of life after they've been through the hospice program, and it's quite amazing to see the outpouring of emotions and how successful the hospice program has been. So congratulations to you, because you're like the standard of doing it.
Well, it takes more than a village, it takes our whole team.
Yeah.
I am very fortunate to be able to work that long in hospice and work with a wonderful team.
Yeah, and I think if so for the viewing audience, I would imagine there's probably people that have never experienced hospice or had a loved one who entered hospice. So maybe you could tell us a little bit about how that works.
So I know a lot of people think that hospice is only for cancer patients, but actually hospice is for any terminal diagnosis. It could be COPD or Parkinson's or ALS. It doesn't have to be cancer. And in our hospice, we see a lot of end-stage dementia patients. And so when a physician is seeing a patient and feels that the time has come that this patient, there's no longer any aggressive intervention that could be done to help that patient, and the focus will now change to comfort, they call on hospice. And so hospice goes out and does an evaluation and meets with the family, and then does a case conference with our hospice medical director and our hospice team to make sure, yes, this patient meets all the qualifications, and then we initiate our services.
Yeah, so talk to us about the experience, not having hospice. So for somebody, for example, who is in that window of maybe 3 to 6 months or something like that, and someone who enters into the hospice program versus someone who's not in hospice. I hear so much about how it was a completely different experience. The family, everyone celebrated the person's life, was prepared for what was going to happen, and really it happened in a much different way. So talk a little bit about that.
So the goal for our hospice is to get a patient on earlier rather than later. I know that I think it's a common misperception that people have to be imminently dying, and that is the furthest from the truth. We actually would love to have patients on for at least 3 months, because then the services that we put out there are definitely much more of a benefit. We have our social workers, we have volunteers, we have our nurses' aides and our nurses, we have bereavement. So we have this whole entire team that meets together, makes up a care plan, and then instead of focusing on the fact that the patient may be dying, we focus on their life and on promoting their well-being and quality of life, and just trying to help them do things that they would not be able to do running back and forth to the doctors and worrying about blood tests, and now just focus on those things with their family that they enjoy. We have volunteers that go out and play cards with them. We'll write letters for them. We've had patients that we've brought, can't get out to the seafood place, so we bring them the seafood dinner. You know, my most special memory is of a young couple, and the husband was going to die soon, and it was their anniversary. So between all our volunteers and our hospice team, we arranged, somebody went out and got the food at one of those restaurants. What's the steakhouse down in Southington? Well, whichever one it was, they got him a steak dinner. Volunteer brought flowers. Everything was delivered. They set it up in his bedroom, and they had a wonderful, wonderful anniversary celebration. It wasn't long after that he passed, but they had that wonderful memory. So those are the things that hospice enjoys doing. We want to promote your quality of life.
It sounds like, so everybody has, you know, kind of a different mindset about the where, you know, so I've known people that absolutely want to be at home, and then there's others that say, I don't want the memory of me passing in my home to be, you know, what my spouse, my loved one, or my kids remember. And it's a very individualized thing. And so how do you kind of work through that? Because obviously that's an emotional conversation.
It is an emotional conversation, and it can be challenging. That's why we have a team, because the nurse can't do everything. We need our social workers, we need our bereavement, we need our chaplain. I almost forgot our chaplain, and that's one of the most important people. And so we have all of these people that join together. I think fortunately, because Bristol Hospice is part of the Bristol Health Network, we have the ability to admit certain patients to our hospital for end-of-life care when they meet the criteria for that. And we also take care of patients in the home setting. And then if that's not feasible, we take care of patients in assisted living or in nursing homes. We do a lot of hospice patients in nursing homes. Ingram Manor, one of our biggest recipient of hospice care for their patients. So it's individualized. We meet with the families. Our social work goes over all the different aspects of what the family and the patient's goals are, and then we go from there. And then once a week, we have this wonderful team meeting with all our hospice medical director and all our team, and we discuss our patients, the issues, the problems. Everybody has opportunity to put in their input, and it helps us develop a more sensitive plan of care for those patients.
Yeah, it's really amazing, and you know, you're there for those patients 24/7, 365. So there's always a volunteer or someone that can respond to a phone call. So.
Yeah. So I think the other misconception about hospice, unfortunately, is that we stay there with them. And I wish we could. I wish if you know, somebody could lobby and change Medicare to give us 24-hour coverage, but 24-hour people in the home. But what we do have is 24/7 nurse availability. So they just have to call hospice, and there's an on-call nurse 24/7, 7 days a week, holidays, it doesn't matter. So patients can get a call back if there's a problem, and they'll get a visit if needed. Middle of the night, Christmas, doesn't matter.
So often, you know, there's a lot of work in taking care of somebody as they're kind of transitioning to the end, and so often a spouse or a child or someone in the family may feel overwhelmed and not being able to really take care of the person to really honor their wishes. As part of this process, that evaluation that goes on, you can bring resources like home care, for example, you know, private duty people, all of those things. And so talk a little bit about that. You know, so in a sense, you try to make the wishes of that individual come to fruition, to really happen.
Yeah. So Medicare puts some guidelines into place to ensure that every member of the team sees this person within a 5-day period, right? And so the social work's already going to evaluate. They're going to know, okay, for now this is going to work in the home setting, but in the future, she also does some financial piece so she knows what they can afford and what options are available. And so everybody's involved in saying, you know, at this point, it looks like they're going to be able to make it. We might encourage family to contact other family members and bring them on board. We definitely use our nurses' aides as well as private agencies that unfortunately the private agency is not covered under the Medicare benefit, but a lot of families are ready to spend that money to take care of their loved one. So everybody's responsible to get that evaluation done so we know how this is going to play out. Now, we know in life things don't always go the way they plan, but we respond immediately to emergencies and usually can work that out in a pretty quick period of time.
So going back kind of where you started from, the whole concept of hospice, sometimes, you know, when you start to have that conversation with a patient, they feel like that's it. Like, we're talking hospice, that's the end. And maybe they didn't hear clearly that, you know, what the physician was telling them. And you know, so how do you, and the other part of that is that often a spouse or a child's like, it's not all right. I mean, there's no way my father, my mother could be on hospice. I look at them, they're fine. It's not going to happen. How do you, like, what, to the audience, you know, how do you overcome that?
So that is a very real, everyday problem. Fortunately, Bristol Hospital is very progressive, and we have a palliative care team. And so we meet a lot of these patients in the hospital. And I can tell you that our conversation doesn't start with the word hospice ever. Yeah. Generally, when we meet families, we'll say, we're going to sit down and have a goals of care conversation. And that sounds pretty harmless, right?
Yeah.
And we sit down with them and we ask them, what are your goals? If the patient is able to tell us, what would you like to see done in the next month, in the next couple of weeks? And then if not, then the family will begin that discussion. Eventually, it will lead into hospice. But from the beginning, we are very careful, unless there's a family member saying we're ready for hospice, and then we'll just go right into it. But generally, we work on goals of care, what's important to you, what is your ideal plan for your loved one or for yourself.
Yeah, so that's really interesting. So you talked a little bit about palliative care. So I'm not sure everybody understands what that means.
Yeah. So palliative care, and I know it gets confusing. So palliative care is goals of care. It's symptom management, and it can be done for any illness at any time during the illness. Patients can go back and forth to the hospital. They can look for curative treatment. It's just that someone is there talking to them about their goals of care, kind of guiding them through the system, making sure the patients have adequate symptom management. And we have what's called our special touch nurse in the home care setting, which follows those patients until such time they're either discharged or they're ready to go to hospice. Yeah. The difference between palliative and hospice is hospice, you've made a decision based on the patient's terminal diagnosis. Generally don't go back and forth to the hospital or have blood work or not seeking curative treatment. So it's a big difference. But palliative is a broad term for care across the continuum for routine patients with just regular diagnoses or chronic patients with terminal diagnoses.
Yeah, so it's kind of interesting. You said, you made the contrast of, you know, generally speaking, palliative care persons going back and forth at a hospital, you know, getting treatment. And from hospice side, that's not necessarily happening. But from a quality of life standpoint, which you talked about a little bit earlier, they're still getting pain management. They're still, the idea is to really do what's necessary to keep them comfortable, right? I mean, is that?
That's correct. The focus is on patient's comfort. So the nurse sees the patient several times at least a week minimum. And then anytime there's an issue, we talk with our hospice medical director. We get our orders in place. We have their medications, which are supplied by the hospice, by the way, too. Anything that deals with their terminal illness and their pain management is supplied by the hospice. Yeah. So the goal is comfort for that patient.
Yeah. So talk to me. So one of the interesting things in our community is we don't really have a hospice house, so to speak. And you mentioned earlier that sometimes the patients could be admitted to the hospital or admitted to a long-term care facility. For those patients that, they can't live out their final days in their home because it's not it's just not an ideal setting, they don't have what's required, or because they don't want to be in their home at the end. So we don't have a hospice house here. I mean, you'd have to drive all the way to Brantford, right? I mean, it's pretty far away.
Yeah, there's a couple of places that offer it, but they have to meet the same criteria actually as we have to meet for inpatient.
Yeah, so talk to me a little bit about that. I mean, we have some private rooms in the hospital.
So we do use some of the private rooms, and a lot of the patients that we see at the hospital that end up going on our hospice program are usually patients that have not responded to the treatment at the hospital, and their condition has declined, such as that they're probably going to pass away very quickly, and they need symptom management that can't be done at a nursing home, can't be done in the home setting, like IV medications, high flow oxygen, those kind of things that would require a lot of suctioning, complex wound care. Those things can qualify a patient for the inpatient level, but we don't routinely bring patients in to admit them to inpatient hospice at our hospital. That's not a Medicare, that doesn't meet the Medicare guidelines, but we do often have at least 1 or 2 a week at our hospital that we're caring for.
So as you were talking through this, you know, kind of, and it's been, I mean, I started at Fox Chase Cancer Center, so the way people transitioned from when I started my career to now is so much better when I think they enter into palliative care than hospice care, and I've experienced it with many of my relatives. But one of the things that I've been very keenly aware of throughout my career is that there are many physicians who aren't completely aware and engaged, and often not making those referrals. So we used to look at, for example, how many days that somebody got into the hospital. We probably still look at this, right?
We still look at it.
So what's the average number of days now running?
I don't have the average for us, but I can tell you, just based on one of the seminars that we recently attended, is Connecticut has the lowest amount of days. People get on hospice closer to death than other states. So it's still not happening that we're getting patients in a more timely manner where we can spend a little more time and meet with the families and deal with the families. So it has changed over the years, and most physicians now are usually on board. We have a couple that aren't, and we work with them.
So, but for the patient, and I can tell you, I lived through this with my father-in-law, who was in hospice, actually went to a hospice house. My wife is one of 9 kids, so big family. And she actually stayed with him in the hospice house and was there with the rest of the kids, because it was all very well coordinated. His wishes were really completely observed. That end-of-life experience for that family was incredible. I mean, he was able to say goodbye. They all talked about it. Everybody understood. It was completely different than what I had experienced with other family members. And so I think the thing that, it's sad to me, it's sad that, you've got this short time frame between getting into hospice, because it really took a lot of time to get everybody on board. Obviously, 9 kids, 9 different opinions. Some of them are doctors. Very strong opinions, as some don't believe, and you find that time really matters in that equation, right? It's if you know it, if you have it, and getting into the program can really kind of, I don't know, I look at it partially this way, that if you don't kind of deal with it before, you're still going to deal with it after. Right. And then you don't have the individual to be a part of that discussion. Does that make sense?
Oh, yeah. No, and that's why our goals when we get referrals is to act on them quickly, because we would like to get to that patient and family and start setting up their plan of care and setting up the supports. After a patient does pass, we have 13 months of bereavement for that family member, which is a very helpful thing. But, more than that, we would love to be able to spend more time getting everybody to that place that they hopefully need to be to have resolution of whatever fears and all they have. I mean, it's not easy. No. Even in the best circumstances, losing a loved one is very difficult.
So let me ask you a personal question. How do you deal with that? You've been doing this for a long time. People ask me that all the time. How do you do what you do?
And I have to say, as I deal with it longer, it doesn't get easier. It actually gets harder. I think as you go on more, you deal with your own mortality, and you've said goodbye to way too many patients. So I have a strong faith, which keeps me very grounded. I'm very active in my church. And then I do things. I took up playing the piano during COVID, right? And I'm pretty good now.
So
okay.
we put one in the lobby of the hospital. Will you come in and play for us every once in a while?
Yes, I'll play. So we do things, and then we do things as a team. Our hospice team gets together and just does something fun to laugh. We do a lot of laughter, and I know that sounds weird, but even with my patients, I use a lot of laughter. It's good medicine. So you have to have some things. I think, you have to stay grounded.
Yeah, I think it's amazing what you do and how patients respond. And as I said, I've been to the celebrations that you have within that 13-month period. It's a celebration of life.
Celebration of life.
And it's amazing to see how many people attend. I mean, the attendance is...
It's amazing.
And you invite everybody from the families that had passed in the prior year, and you fill that church every time. It's just amazing. And it really does, I think, bring closure to the experience. And then it's people sharing common experiences that helps that healing process, right? So
families come and they want to see their nurse, and you get to see how they're doing afterwards. It's quite emotional time.
Oh, yes.
It's a good time. It's emotional, and it's needed for both the nursing, the medical, the social workers, everyone, and then the families.
Yeah. So if someone is in this situation and they don't necessarily haven't presented it with the option, but they know a reality is in front of them, what do you recommend they do?
So they can do one of two things. They can call their physician and ask them to make a referral to the hospice agency, or they can call our hospice agency directly, and we'll help them through the whole process. We'll contact a doctor. We'll take care of all of that.
So suppose it's, and this can happen, suppose it's the spouse, but not the patient themselves. Is that still okay?
Yeah, it's usually as a family member. It's pretty rare that we have the patient call us for it. It's usually a family member calling for them.
That's interesting. I hadn't really thought about that. So they make the call, and then you can go back and talk to the physician if it's necessary.
Yeah, we need a physician's order to say, hey, so-and-so called. Is it okay if we go out and do our hospice eval? And then we go out and do the eval, and then we update the doctor with our findings, and he says yay or nay, and that's how it goes from there.
Yeah. So advice to people who may, and sometimes, and it's like a 6-month window, is that?
It's a 6-month window.
6-month window for it to be approved and paid for by insurance companies, right?
Yeah, so a doctor has to, actually 2 doctors have to sign off that this patient has a terminal diagnosis that could potentially take their life in 6 months or less.
So how often does that get reversed?
So I have, at Ingram Manor, I have a couple of patients that have graduated because depending on the diagnosis, it's rare in cancer patients that it's ever reversed, but sometimes in dementia patients, or, every now and then we know what we know at the time, and it's not that often, but it does happen.
Yeah. So any last words for our audience? I mean, this has been incredible, Sophie. You educated me as well. So
no, just if you have any questions, feel free to call the Bristol Home Care and Hospice Agency, and we'll be happy to contact you and answer any questions that you have.
Thank you so much for being on the show. I really appreciate it. And this is Bristol Health Cares. And as I've said in the past, you can write us to cares@bristolhospital.org. And I'm happy to bring on folks like Sophia here and talk about important topics that you want to hear. And I'm really looking forward to seeing you in a future episode. I also want to say a special thanks to Nutmeg TV and the production crew that does a phenomenal job here. It's a wonderful community asset. I encourage you to support this asset with your donations and support. So thank you. Until the next episode, have a wonderful day.